welcome back, everyone. We are going to kick off our next session, and I'm really honored to be able to introduce our next guest speakers. Diana Camacho, who's a Senior Program Officer at the California Healthcare Foundation, and Renee DuPré, Senior Director of Measurement and Accountability at the Purchaser Business Group on Health. I'm going to share a little bit about both Diane and Rachel's background real quickly. Diana Camacho is the Senior Program Officer at the California Healthcare Foundation, CHCF, where she is on the Improving Access team, which works to improve access to coverage and care for Californians with low incomes. Diana leads CHCF's body of work on telehealth, and she's led several initiatives to advance the use of telehealth in the safety net, including Connected Care Accelerator and the Virtual Care Innovation Network. Prior to CHCF, Diana worked at Kaiser Permanente, where she led Medicaid care delivery, collaborations, and national community benefit grant making within the healthcare safety net. And additionally, Diana has a healthcare and public health experience in the areas of public policy, language access, community needs assessment, and diversity, equity, and inclusion. And Diana started her public healthcare career supporting the needs of people living with HIV/AIDS as a case manager and a health educator. She earned her bachelor's degree at the University of California, Santa Barbara, and a master's degree in public health from the University of California, Berkeley. We are so excited to have Diana here. And a little bit about Rachel. Rachel DuPré Brodie leads multi-stakeholder initiatives to advance healthcare quality and put performance information to use for payment and decision-making. She's leading an initiative to demonstrate the feasibility and impact of collecting and using outcome measures for value-based contracting and payment, and address barriers for collecting patient-reported outcomes. And she's also leads a measure, development of patient-reported outcome performance measurements, what are called PRO-PMs for oncology care. Other measurement and reporting collaborative work includes the Patient Assessment Survey, a Telehealth Patient Experience Survey, and the California Joint Replacement Registry, for which reported results of hip and knee replacement surgeries, including PROs. And Rachel received a bachelor's degree from Princeton University. And with that, Diana and Rachel, the floor is yours. Thank you for being here today.
Thank you very much, Jennifer, and thank you all for being here today. I'm really excited to be talking about some work that CHCF has done to listen to Californians about their telehealth experience. And so for those of you who are not familiar with the California Healthcare Foundation, also known as CHCF, we're an independent philanthropy based in California. We focus on improving California's healthcare system for those with low incomes, with a specific focus on the Medi-Cal delivery system. We have been investing in telehealth as a strategy to increase access to care for over a decade. Since the start of the pandemic, it's been more of a focus, and my two central goals with our telehealth work have been achieving equity and access to telehealth, as well as scale, making sure all practitioners across the street are really using telehealth to its full potential. We do this through investments in the care delivery transformations. We have funded several learning collaboratives with FQHCs and other safety net organizations across the state. We also invest in data and research, such as this project, and we do that to foster monitoring and transparency on what's happening in the telehealth market. And we also support policy development and execution, such as our support for an organization called the California Healthcare Telehealth Coalition. So CHF views listening and lifting up the voices of patients and consumers as a key mechanism to advancing health equity. Healthcare practice and policy needs to be informed by the people it serves, and we will not be able to right historic harms until we've listened to and responded to their needs. So what we'll be highlighting today are two projects centered around listening to patients. One is a deep listening project, which I will discuss, and then I'll hand it over to Rachel at Purchaser Business Group on Health to highlight survey work that they conducted in CHF to help to support the dissemination of. The goals of these research projects were to understand and raise awareness of how Californians with low incomes access and experience telehealth. And we hope this research informs the work of those in policy, of other philanthropies, of health plans, and our provider partners. So with that, I'll jump in to talk a little bit about the study that CHCF commissioned. So what did we do? Any good research presentation starts with the methods. At the time this was envisioned, I was seeing a lot of polls out about telehealth, quick questions asking people about their telehealth experience. These polls were great, but they only captured the basics of access. Did you have a visit? Yes or no? Did you like it? Yes or no? The polls were lacking a deeper look at the impact of access to telehealth, the barriers and facilitators in using telehealth, and the preferences and people's preferences related to telehealth. And most importantly, the voice of the patients about what works, what doesn't work, and recommendations on how to make telehealth better. So we decided it would be meaningful to conduct 1-hour in-depth interviews that really went deep with low-income consumers from California, healthcare consumers from California. And we really wanted to focus on patients that might experience more barriers than others. We knew from other work that patients who preferred to receive their care in another language, and so non-English language, had many telehealth access issues. So we oversampled the top 3 non-English languages in the Medi-Cal program, which are Spanish, Cantonese, and Vietnamese. We also made sure to get representation across races and ethnicities, geographic areas in California, and ages. Ultimately, our researchers at NORC interviewed 73 Californians with incomes less than 200% of the federal poverty level that had diverse backgrounds. Notably, 58% of these were Medi-Cal enrollees. We had some dual eligibles, we had some Medicare, but all of those were low income. And all people had experienced a telehealth visit in the last year. I want to call this out as a potential limitation because while the data shows that most people had a telehealth visit during the pandemic, we recognize that the sample would not capture the experiences of people that may have the most barriers to care and have not engaged with the healthcare system. So I think that's really important to note. Today, I'm going to walk through the findings, but I urge you all to check out the full report. The link will be at the end of this presentation. It's full of rich quotes and findings, all of which I will not cover today. So with that, we'll go to the next slide, and I'd like to share a few videos. We made some videos that highlighted the people that we spoke to, and we will start with one overview video, and then we will end the presentation with another video. So if you could play the video, please.
Hello.
Hi team, this is Dr. Chung. How are you doing?
I lived at a time when the doctor did house visits, house calls, and actually I compare this to that. I feel like I'm having house calls again.
I think having telehealth is awesome. It gives you an option, especially for people like me who suffer from anxiety. One minute you be okay, and the next minute you be panicking. You be like, oh my God, I gotta go to the doctor. Oh my God, I gotta go outside and let out, And then you could just make that call and say, can we switch it to, a telehealth, because right now I just can't go outside. So it works. It works.
I'm a student at Cal Poly Humboldt. Telehealth has really addressed a lot of my needs. Living up here in a rural area, getting labs, seeing a specialist, it can be a very long wait. When students aren't able to access healthcare, I've usually seen them turn to substances here. Telehealth really helped me access safe healthcare a lot easier.
For people like me who have so many things wrong, and if I walk 10 steps, I can hardly breathe, telehealth has really helped me in that way.
Your breathing is okay, right? You're
My
not short of breath or
breathing
anything like
is good. My breathing is fine. And I have this doctor, his name is Dr. Chung. I trust Dr. Chung 100%. I truly believe that Dr. Chung doing telehealth with me has impacted the bonding in our relationship in my health care. Usually when the doctor tells me something, I come home and do what I want. But what Dr. Chung tells me, all of his suggestions, I will follow through on. I feel better than I have felt in over a year.
And how did you notice the anxiety this morning? The answer is that you go to the house and utilize some other resources. You went to the
I like to see your facial expression when I'm sharing my problems with you and see if you feeling me or you're listening. When you have somebody totally focused on you, that make you so relaxed and it makes you feel heard.
They gave me the option of FaceTime or the iPhone. And I said I wanted the iPhone because there are times I just don't look that good. But they gave me that choice to begin with. It was very important.
So a lot of shifts in positive directions over the last couple of weeks.
The people who are typically in this area who are healthcare providers are typically white and straight. In that aspect, I feel like it could bridge that gap of healthcare access with diversity. It wouldn't just be from this area. It could be someone from San Diego or even from even lower part of SoCal. Being able to open our choices up to a much broader area.
We have seniors and we have handicapped. Some just can't get out of bed. You have to make it, where it's easy for them to be able to be seen instead of punishing them because they can't get there. I like telehealth because they're making life real easy for people who can't do.
I think so far it's been a very useful tool and very helpful. If we could find a way to get telehealth to be kind of just this broad, universal thing where no matter where you are, if you need care in this second, you can get it. That would be really nice.
Thank you very much. I hope you enjoyed the stories of Stephanie, Jean, and Jesse. We'll go deeper into Stephanie's story at the end of the presentation if we have time. So first, I will share what we heard about access to care with telehealth. Do the next slide, please. The main finding is that telehealth improves access to care for many people by removing barriers. A 44-year-old Latina woman in LA told us, "We need that appointment, but we hesitate because we can't ask for time off. With telehealth, we can work around our lunch or break schedule." A 23-year-old Black man in LA told us, "I'm more likely to get care because I know I'm going to be able to reach out and get an answer quickly instead of trying to reach out and go through a prolonged process." We also hear clearly that the ease and convenience of telehealth helps people to make and keep appointments that may not have happened in person. We asked about technology barriers, and interestingly, a minority of patients encountered tech challenges when trying to access telehealth. Again, these are people that had a telehealth visit in the last year, so there might be a sample limitation, but overwhelmingly across the board, people of different ages and backgrounds all said, with a little bit of support, they were able to figure out the tech issues and use telehealth. Maybe not the first time, but with some help, definitely the second time. Next slide, please. When asking patients about what could help them, many reported that it worked well when they received links via email or text before the visit. We also heard clearly, and this is a theme that's going to come up throughout, that people appreciated having choice in what modality of telehealth that they received. Next slide, please. Some groups of people in particular spoke to how telehealth improved their access to care. Those include people with physical disabilities who aren't able to easily travel. An 84-year-old woman from Riverside told us, "Every time I go to the doctor, I'm really exhausted the rest of the day and the next day. So with telehealth, I remain well. I remain doing the activities I'm able to do, and I don't get shortness of breath and wiped out where I lose a whole day." We also heard that telehealth is particularly helpful to people with mental health conditions who, due to their conditions, may not be able to get to the provider to get help. A 50-year-old woman in the San Joaquin Valley told us, "I've been struggling with anxiety and depression, and not having to go in makes it more likely I'll actually do it. I feel like it makes it easier to get care on some things that wouldn't necessarily otherwise, instead of only getting care when it's something serious." And we also heard that people who identify as transgender or non-binary are able to better connect with providers that are compassionate around their needs, much like Jessie, whose story we heard, who was in the rural Northern California, who felt like there was a lack of providers compassionate to their needs in that area. The next area we spoke to folks about was how they experience telehealth, not just their access to it. Next slide, please. Overwhelmingly, participants expressed high levels of satisfaction with the care they received via telehealth. And these are really profound findings to me. We heard how telehealth helps to strengthen relationships by helping patients to build trust with their providers through more frequent and easier contact and better follow-up. A 24-year-old man in LA told us, I think that telehealth visit was more one-on-one. He didn't have to rely on other people because sometimes when I go in person, the doctor is going back and forth with the nurses. So it feels like the time is more personal. We also heard about common dissatisfactions of telehealth when you go for a telehealth visit and then you need a follow-up in person. And that's in many instances, people felt like telehealth felt like gatekeeping. A 44-year-old man from the San Joaquin Valley told us, I've been struggling with anxiety and depression, and not having to go in makes it more likely I'll actually do it. So there's lots of themes here around people generally liking it, but being somewhat dissatisfied with their visits when it felt like gatekeeping. Next slide, please. I want to call out these two areas we dug into with our interviewees because these were important topics that have come up in California. Language access, when you receive telehealth in a patient's preferred language, and the use of phone versus video, so modality choice. For language access, we heard that patients had a good experience when their provider spoke their language. Kind of a no-brainer, but really important. But we also heard of instances of patients having family members interpret, which is actually a big no-no and violates some of the civil rights of our patients. Patients talked about problems with scheduling mechanisms only being in English. And I also want to note that the researchers, and I do believe that this study likely understates language access issues because the people we talked to all had telehealth visits. Other data we have seen shows that many limited English proficient patients may not have been able to even access telehealth in the first place. And then regarding phone versus video, so modality choice, which was a hot topic in the policy reimbursement world, participants saw the value of both and offered pros and cons for each. So for phone, it's easier to set up than video, and there's fewer bandwidth or connection issues. For video, people felt the provider can perform some exams. They also felt it was easier to establish rapport with their provider over video, and they had more confidence that the provider was paying attention. When tech challenges came up, which I mentioned weren't that often with this group, video was often the culprit on either the patient or the provider side. And lastly, I want to touch on future preferences for telehealth before I talk about implications for what we learned. Not surprisingly, patients want telehealth to be an integral part of their care in the future. In many cases, participants stated that they wanted 50% or more of their healthcare via telehealth, which is actually a lot of healthcare and is more than we're currently seeing in the California safety net, which is hanging around 30% for primary care. And actually it's around 60% for behavioral health. When asked about what modality they wanted, preferences varied and were very personal. A 24-year-old man in LA told us, an in-person visit just seems more real, more solid. It's just that being with another human being and talking in person in the flesh. While a 66-year-old man in LA told us, if something requires a thorough physical examination, it would be best to go for an in-person appointment. And then for everything else, I like video and telephone. You can do either or in most cases. So as you can see from these two quotes, it kind of defies our common assumptions where a young person actually wanted in-person and a senior wanted telehealth. And so I think this raises the issue, the need for really taking into account patient preferences and asking them what they want. And this, this theme of choice came up a lot. Most participants want to choose their modality or decide with their provider. There was a great quote I heard from that same 66-year-old man in LA. I think as a patient, I would prefer to have the right to make a decision, because it isn't that what I'm paying for? I'm paying the doctor to help me out in whatever format there is. And if you go to the next slide, I think my slides are a little off. Actually, back a slide. Back a slide. Back a slide, please. Okay, looks like there might be one slide missing, but I'll go ahead and just talk to it. So one thing that came up that I really want to call out is equity in telehealth. For many of our participants, telehealth has facilitated a beneficial cycle that starts by telehealth improving access by removing barriers. When those barriers are removed, relationships between patients and providers are strengthened and trust is built. Strength and trust, I think we can all agree, is particularly important for people who have historically been harmed by healthcare, which can result in disengagement and ultimately health inequities. With more trust, they feel more comfortable accessing and engaging care, which can lead to better health. And I think we've heard from talking to people that telehealth was important in helping to build that trust and strengthen relationships. I want to speak, if you could go back a slide, please. I want to speak a little bit to what the implications of some of these findings were in the study that we did. So first, the report calls out implications of these findings, but I think these are probably no-brainers for many of you, but I'll just talk through them. First of all, we need to support access to all modalities of telehealth. So not just video, not just phone, not just in person, and we need to give patients choice. We need to really make sure we're seamlessly integrating the use of interpreters and using language concordant providers, so providers that speak the patient's language. We really have an opportunity to embrace telehealth for key groups, such as people with mental health issues, or those with disabilities, or those who identify as transgender or non-binary. We really need to improve the integration of telehealth and in-person visits to address this issue of people felt with gatekeeping and not being the right appointment type. We heard about the need to use email, text, phone, and patient portals to support continuity of care for patients. We need to make sure that both patients and provider have good connectivity, which includes access to broadband, devices, as well as health literacy. And we need to improve support for accessing telehealth. As I mentioned, when people said that they got support and someone helped them get on their telehealth visit, they were able to do it in the future, and that really helped them. So with that, I will go to the next slide, please. And we will end with a deeper dive into Stephanie's story. And I hope you enjoy. And after that, I'll hand it over to Rachel to talk through. And I think we'll take Q&A at the end. So please put your questions into the chat. Thank you.
I have a picture frame that was custom. Yep. And it has a photo inside of it. So I'll go grab that and then we can install it so that
my name is Stephanie Gutierrez. I'm 56 years old, and I live in North Oakland, California. I was working at California check cashing, and I picked up a large bag of money. And they didn't teach you how to pick up money, so when I picked the bag up, it brought me down, and I snatched it back up, and then my whole life changed. I messed my back up. When I hurt myself, I couldn't do a lot. I really couldn't walk from here to the door without crying all the time because I was in so much pain. I was active, but then when I got hurt, I stayed in the house because I couldn't do anything anymore. I had to be dependent on people, and I was an independent person. It makes you so sad. After getting hurt and taking all these other pills, seemed like it made different things awaken. One of the biggest is my anxiety. But then I have diabetes, I have high blood pressure, high cholesterol. I take my medicine, go see my doctor. That's a task itself. And I like telehealth. It gives you an option, you know what I'm saying? Especially for people like me who suffer from anxiety. One minute you be okay, and the next minute you be panicking. You be like, oh my God, I gotta go to the doctor. Oh my God, I gotta go outside and let out, you know. And then you could just make that call and say, can we switch it to, you know, a telehealth, because right now I can't. I just can't go outside. My therapist, I see her every 2 weeks. Hi, Kaylin.
Hi, Stephanie.
I enjoy communicating with her. She helps me.
And how did you notice the anxiety this morning?
She helps me be calmer. She's given me tools to, you know, teach me how to redirect some of this craziness that be going on in my head that stops me from going outside. You know how much I be having that hard time where I'm so unbalanced that it's good that I'm balanced. I like to see your facial expression when I'm sharing my problems with you and see if you feeling me, or you know you're listening, because I've had few that like they don't listen to you. When you have somebody totally focused on you, that make you so relaxed and it makes you feel heard. You help me a lot.
Oh, well, I'm glad. Well, you are really the one that does the work.
To have the choice of being able to sit at home, talk to your doctor on the phone, or just go in the office and see him, that's a awesome thing. I basically don't even like to go outside, but I do. I'm feeling a whole lot better. I know I might not get to be where I was, but at least I'm not as afraid as I used to be. If you had your mom or your aunt or whoever, they could be a senior, and they weren't able to get to their appointment, or they don't have anyone to take them, you have to make it, you know, where it's easy for them to be able to be seen instead of punishing them because they can't get there. I like telehealth because they making life real easy for people who can't do.
So again, thank you. I encourage you to check out the report. And we also have 2 more videos highlighting Jesse and Jean's story. It was really a privilege to get to do this project, listen to people, lift up their experience, and very meaningful, I think. So with that, I will hand it over to Rachel and we'll take Q&A at the end. Thank you.
I am here, Rachel. So when the slides are ready. Okay, thank you. I thought I'd start by providing a little bit of background about Purchaser Business Group on Health, my company, or PBGH, then describe our patient assessment survey program, describe the telehealth patient experience survey that we developed, and then our findings. And I think you'll see that many of the points that the patients raised in those videos align with our survey research findings. So it's hopefully helps with the story that we're trying to tell you today. So next slide, please. Okay, so PBGH is a not-for-profit coalition of approximately 40 member organizations, including private employers and public agencies, representing some of the largest purchasers of healthcare benefits in the United States. Our members represent approximately 21 million Americans and spend more than $350 billion a year buying healthcare for their employees and families. These are purchasers like high-tech companies like Cisco and Salesforce and Microsoft and eBay, public agencies such as Covered California and CalPERS, the Public Employee Retirement System, and other large employers like Walmart and Boeing, Chevron, Costco. So they're very motivated to ensure that the billions of dollars that they are spending for healthcare is paying for high quality care. And a big priority for our members is that employees can access high quality care, and whether the experience with their providers was satisfactory or more than satisfactory. So our initiatives advance care redesign, value-based purchasing, and policies related to performance transparency. Our strategic goals address affordability, quality, and equity is a very large priority. Okay, so next slide. A little more background before talking about the telehealth patient experience survey is that our patient assessment survey program, or PAS, is the largest statewide patient experience program in the country. And we've been gathering patient feedback and producing provider organization ratings since 2001. This program is led by a multi-stakeholder steering committee. So several provider organization representatives and also health plan representatives guide this work. And every year we gather feedback from about 40,000 commercially insured patients across 176 provider organizations in California. 11 health plans participate in the initiative, and we field an annual survey each year using email, text messaging, snail mail, paper mail, and also phone follow-up. Next slide, please. So each year with those survey results, we produce scores for 5 composites listed on this slide. So access to care, provider communications, care coordination, office staff, and then the overall ratings ask patients about their overall rating of the care on a 1 to 10 scale, and overall rating of the doctor on a 1 to 10 scale. And then these results are used for quality improvement. They're fed back to the organizations, and also are used as part of by health plans participating in the Integrated Healthcare Association, or IHA's quality-based incentive program, and then also publicly reported for consumers through the California Department of Managed Healthcare's Office of the Patient Advocate Healthcare Quality Report Cards website. So we've leveraged this program to be able to conduct research on things of importance and also innovation. So examples are behavioral health screening and access questions that we fielded and published research about, and then also the telehealth patient experience survey that I'm going to describe now. Okay, next slide. Okay, so as we know, the COVID-19 pandemic sparked a rapid expansion in virtual care. So PBGH wanted to understand patients' perspective on telehealth services, and particularly for those patients who might face obstacles to effective use due to language, economic, or structural factors. So while our belief was that telehealth could improve access for lower socioeconomic patients who may be impacted by things such as lack of transportation or inability to take time off work during physician office hours. We also wondered if lack of technology or internet access or privacy could impact the experience and success of the telehealth visit for these patients. There's also research to show that economically disadvantaged populations tend to use video telehealth visits less and rely more or to a greater degree on telephone connections with their provider. We presume that this is due to less availability or the cost of broadband access and smartphones. So we wanted to understand if video telehealth visits provided more value or equal value to patients than phone exchanges alone. So we fielded a telehealth patient experience with California patients who had a primary care telehealth visit in order to understand the impact of telehealth on access and outcomes of care, and also whether there were disparities in experience based on type of insurance coverage, racial and ethnic identity, or primary language. Our objectives were to inform providers, payers, policymakers, and other stakeholders about the experience with telehealth services, compare the quality of patient experience between commercially insured and underserved populations, and identify opportunities for improvement. Okay, next slide. Okay, so about the survey. We developed this survey working with health services researchers, providers, also health plans payers. We wanted to understand how patients were experiencing the technology, what we could learn about the differences between video and telephone visits, what types of visits are most appropriate for virtual care, and what aspects of the patient experience might be obstacles or success factors. So the survey comprised of 22 questions plus 10 demographic items. So the questions asked about the type of visit, the ease of use of technology, if the office provided pre-visit instructions, questions about communications with the doctor, care coordination, and whether follow-up tests were ordered and completed, overall ratings of care, if the respondent would recommend telehealth to family and friends, and if they wanted to continue using telehealth. And then the 10 demographic items asked questions about age, gender, race, ethnicity, education level, primary language spoken, self-reported general health, and self-reported mental health, and also questions intended to assess health equity issues in a telehealth setting, like internet access, availability of technology, comfort with technology, and whether there were concerns about having enough cell phone minutes or data. Okay, next slide, please. Thanks. All right, so we fielded the survey in the fall and winter of 2020 and also the spring of 2021. The survey respondents included about 1,400 patients with commercial and Medicare Advantage insurance receiving care from 13 provider organizations in California. A second survey included almost 1,600 patients with Medi-Cal coverage seen by both Northern California and Southern California community health centers. The patients all had telehealth visits with their primary care providers between 1 and 3 months prior to answering the survey. Okay, next slide. Okay, so to start with key findings and trends. In terms of key findings, the overall, what we found is that most users rated their telehealth experience very highly. So over 70% of respondents rated the telehealth visit a 9 or 10 on a 10-point scale. So that was good news, and I think aligns with what Diana spoke about before. The patients who were not meeting with their established provider for the telehealth visit did rate all aspects of the visit lower. The data showed that the history of the relationship between the provider and the patient was very important. Patients who met with their established provider during the telehealth visit were 20% more likely to rate the visit highly than those who did not. Patients who saw their regular provider also rated all of the communications questions about 15% higher than those who did not. So that was a very significant difference. Next slide. Okay, so patients using telephone rather than video rated all aspects of the visits lower, so less highly. This slide shows the ratings from video visit users in dark blue compared to phone visit users in lighter blue for the communications questions. So one thing that's important to note here and in all the slides is that we generally consider a 3% difference to be statistically significant. So respondents who had a video visit rated whether the provider explained information so that it was easy to understand, whether the provider listened carefully, spent enough time, and had the medical information needed, all significantly higher than respondents who had phone visits. So even though these bars look close in height, these are actually, 6 to 8% differences, so very significant. Okay, next slide. Another key finding was that patients with Medi-Cal coverage rated their telehealth visits much lower than commercial and Medicare Advantage patients, on average about 8 to 10% lower, and particularly when rating communication with the provider. So the commercial patient ratings are in dark blue, are all significantly higher than the respondents who rated this with Medi-Cal coverage in light blue. One thing we did was we looked at whether, if we risk adjusted these results, if this difference would still persist. So we looked at age, gender, race, ethnicity, education level, and also language spoken at home. But this discrepancy persisted. So those demographic factors did not explain the lower ratings from the patients with Medi-Cal coverage. Next slide, please. All right, so we wanted to do, drill in, go a little bit deeper to understand the lower ratings from the Medi-Cal enrollees. So we looked at the mode of telehealth care most commonly used by patients with commercial versus patients with Medi-Cal coverage. The Medi-Cal patients were far less likely to use video, 33.2%, than the commercial patients, which use video, 78.6%. The greater use of phone for telehealth by patients with Medicaid coverage has also been found in other research, so this was not surprising. But this discrepancy in the use of phone rather than video-based telehealth care, it does have several implications. First, there is research showing that phone users may receive less value from the telehealth visit than video users. Providers are less able to examine the physical condition of the patient, less able to take visual cues from the patient, and also make eye contact. I think Stephanie spoke about that in her video. Less able to build trust, and less able to see the condition of the home environment also. The quality of communication in general may be worse when it's a phone conversation versus video. In our results, the patients who use the phone for their telehealth visits rated communications about 5% lower than video users, and were also 8% less likely to get recommended follow-up care. And this was across all phone users compared to video users. But then those discrepancies were even larger for phone users with Medi-Cal coverage, who were almost twice as likely to rate provider communications poorly than commercial patients. So pretty striking differences. Next slide, please. Wanted to talk a little bit about care coordination. Both commercial and Medi-Cal patients were generally successful at completing the tests following a telehealth visit, tests that were ordered by their provider. But across the entire survey population, patients who rated the quality of communication with their provider more highly were also more likely to complete a recommended test. So if they rated communications highly, they're more likely to do the follow-up care. And this makes sense in that how well a provider explains things to a patient and shares needed information would influence whether the patient will follow up to get their ordered tests. Patients were 3 to 6% more likely to follow up when providers explain things well. Should I take a question now or hold that? I see there's a question from a participant. I'll hold it unless you tell me to stop. Okay, let's go to the next slide. few more things that were interesting and looking, trying to understand the differences here. We wanted to see if there are other important differences between the commercial and Medi-Cal respondents, besides the greater use of phone visits. The Medi-Cal population rated their own physical and mental health more poorly than the commercial group. 31% of the Medi-Cal patients reported that their physical health was poor or fair, compared to only 17% of the commercial patients, for example. There was a similar discrepancy for self-reported mental health. So what we took from this is that more patients with Medi-Cal coverage are coming into the telehealth visits carrying more physical and mental health burden. Okay, so next slide. To try and put together a lot of information here. What we found, that was very important is that patients rated their telehealth visit experience highly, regardless of all these, issues that we've sort of unearthed. But it was a more poor experience for patients with Medi-Cal coverage. Medi-Cal patients consistently reported less satisfaction with their telehealth experience, typically 8 to 10% lower than commercial patients, but still on the high side. So the greatest clinical concern suggested by our data is the lower rate of completing recommended follow-up care for those patients enrolled in Medi-Cal. The lower follow-up rate seems to be associated with less effective communication between the provider and patient. We also, related to this, presented a lot of data about significantly higher ratings for video visits compared to telephone visits. One note is that the Medi-Cal patients did report that they were less likely to receive preparation for video visits, but there may be other reasons that they were less likely to use video. Continuity of care is also important. The patients who met with their established provider were 20% more likely to rate the visit highly, as I mentioned. The value of the telehealth may be affected not only by the mode of communication, but by the strength and history of the relationship between the provider and patient. Patients who met with their established one thing we found is that not only if they were with their established provider, were they more likely to rate the visit highly, but this finding related to the type of insurance coverage. So 73% of Medi-Cal enrollees met with their regular provider during the telehealth visit, which was lower than commercial patients who reported 84%. So that was 11% difference. So let's see. In terms of disparities that we found, we attribute some of this disparity to the greater use of phone visits for those with Medi-Cal coverage, as well as lower likelihood of seeing their established provider. The Medi-Cal patients also reported they were less likely to receive preparation for video visits, as I mentioned, but we don't have the full story here for sure. So I think it's just helpful research to consider. However, I do want to go back to saying that overall, despite some variation in how patients rated their telehealth visit, the vast majority of patients, whether they had Medi-Cal or commercial coverage, these were very high ratings for their telehealth visit. They rated provider communication skills highly, generally followed up on recommended tests and were able to get their test results without difficulty. So just very favorable results were found for all ages, genders, racial and language groups, and across the range of visit types as well. So generally, some very encouraging results. Patients want telehealth. They think it's a great value, but there are some things, I think, from a policy perspective or quality improvement that could be worked on to improve that for patients, with Medi-Cal coverage or just more confounding factors. So those were my slides. I did see questions starting to come up. Okay, sorry, let me look at these. Did these surveys include non-English or limited English speaking? So yeah, yes, we did have the survey available in Spanish and also English. I will say though that, well, I mean, we did have it. These surveys were all emailed for the telehealth survey. So there were links for both the Spanish survey and the English speaking survey, English language survey. So yes, those two languages were available, not other languages though. So, you know, that was definitely probably a limitation. Okay, so in terms of this, there's a question about for the Medicaid poor communication rating with telehealth. Is there a control data comparing ratings by payer population for in-person visits? One thing that we could do, because we have the annual statewide program that I described in the beginning, was look at commercial ratings of their telehealth visit, kind of benchmarked with our annual in-person. Our annual survey covered in-person visits as well as telehealth. So within that commercial group, we could compare ratings across types of visits, and we did not see discrepancies. We didn't see big differences between an in-person visit and a telehealth when we were just looking at the commercial population in our annual statewide survey. We don't have the same ability to benchmark and do comparison looking at patients with Medi-Cal coverage though, because they're not included in our annual survey.
Can I say something about that quickly?
Sure.
So I'm having worked in Medicaid, I'm assuming actually in a lot of ways, the Medicaid patients struggle in our health system. There's just a lot of barriers, and people, as you noted, are suffering from more physical and emotional distress. So all I'm trying to say is, I'm not sure that telehealth in particular serves that population worse. My hypothesis would be that they are similarly dissatisfied with in-person encounters, and I would argue that at least they're getting better access options through telehealth. So it's a theory, but it's interesting to compare versus kind of, some people might blame telehealth and say, oh, well, you know, it's not good enough for Medicaid. So just different avenues to explore.
And I actually, I mean, still these ratings were very high, but that discrepancy is something to consider. And I agree with you. These patients are coming in with more concerns, more burden. So, you know, what can we do to ensure that the communications are as optimal as possible, because it is so important. I mean, we just saw these videos, these patients talking about how if it wasn't for telehealth, I probably wouldn't have made it to my visit. You know, I wouldn't have had the visit if I wasn't able to do it over the phone. So I didn't have to leave the house or find transportation, or, you know, they've got more disabilities even. So yeah, I think it's an excellent point, and I agree with you. And I definitely didn't want to only emphasize the negative, and that these are still very high ratings, even from the Medi-Cal patients, probably because they really appreciated that they were able to have an appointment with their provider, especially during, you know, 2020 and 2021.
Yeah, absolutely. Those are great points. And I would also just suggest this population needs so much support. So is there more we can do with options with telehealth, that you could provide them with written summaries, or frankly with subtitles, or just more ways for people to process the information? Because there's been some compelling, even qualitative studies showing that a lot of people during these doctor visits can have high anxiety, just maybe not feeling comfortable talking to somebody who they perceive as very different from them, or a different education level. So I would love for us to support them in as many ways possible.
I want to comment on that, Lisa, as well. CHCF will be releasing in a few weeks. We did an analysis of CHIS data, the California Health Interview Survey, which is survey data, and kind of addresses some of your questions. And this will be a report coming out in a few weeks. But essentially, what you're saying is, in general, the patterns of telehealth use track with broader patterns of having seen a doctor in any setting. And so what you're saying is like, yes, similarly, they use less healthcare generally, and they use less telehealth. But we did notice from the CHIS data, there were some differences that suggested some particular subgroups were not tracking with that trend. In particular, those who do not speak English or have less English proficiency. So there are instances when it doesn't track with that overall trend that we can share more on with an upcoming publication we'll have out in a few weeks.
Yeah, that would be great. I'm glad you brought that up. And I guess maybe to refine it briefly, I'm really interested in how much value we're getting from our healthcare dollars. So not just who's going to the doctor or, in person or telehealth, but when they go, do they understand what's going on? Do they feel supported? Like it was nice to see in that video. Someone saying, wow, I really felt seen. I really felt supported. So how do we enhance that so that the dollars we're spending for care is really helpful to the patient, and also that will inspire more consistency of getting medical care and hopefully using pharmaceuticals correctly. Like there's a lot of waste in the healthcare process where on paper, delivered care, but the person wasn't engaged, didn't understand what was going on, isn't clear on the next steps, or their caregiver isn't clear on the next steps. So that's also what I was considering.
Thank you, Lisa. I see another question in the chat related to, are there already established services for telehealth interpreters? We'll love to hear more about that. So Mariah, thank you for responding. There is a session on language access later today where you can probably learn more about that. I'll share, CHCF has supported learning collaboratives of health centers across the state to engage in telehealth equity work. And one of the focuses has been language access. And what we have seen is that in the early days of the pandemic, when organizations were kind of forced to just turn on telehealth overnight, those workflows and technology were not yet established. And so patients' ability to either bring in a third-party phone interpreter were really hard. Some of those capabilities didn't exist. And even bringing in like a third-party video interpreter was like nearly impossible in the early pandemic days because that wasn't built in. Since then, though, there's been a few vendors that provide interpreter services and telehealth access that have figured out ways to do this. And so we're seeing more and more organizations adopt that. But I will say there is from what I've seen in the work that we have supported, there's a long way to go to ensuring that interpreters are integrated seamlessly into telehealth visits. So again, I think the theme here is people like it, people want it, and there's more work to do to ensure that telehealth realizes its full potential.
Thank you so much, Diana and Rachel. I do want to just read out one question that was submitted through the Whova platform. Teresa asks, do you observe improved compliance with telehealth visits, i.e. fewer no-shows and better follow-up visits? And did a majority of patients polled indicate that they lacked reliable transportation, or was transportation available, cumbersome, etc.?
I will say from the study that we did, when we talked to folks specifically, we did hear how telehealth helped them to make appointments and keep appointments. It's not something we looked at quantitatively, but we asked qualitatively, and that was a clear theme that came out, that essentially telehealth helped them to keep appointments. And I saw you probably heard some of those themes within the videos.
Yeah, and we did not assess that in our survey. But I have heard the same type of anecdotal evidence. And I'll just say there is more detail about our report at this link if anyone wants to see the full survey, the full report. So
yeah, thank you very much. One last question. I know we have just a minute left. Any thoughts about pairing the telehealth visits with a nurse home visit sometime in the process to allow providers access to the patient, their home, their community, to see if it might build trust between patient and provider, especially for PTs with multiple confounding factors, a hybrid model to bring care to the patient? So I think asking about a nurse at home during that patient interaction.
That's not something that we heard about in any of our studies thus far, but I will say a thread that to pull there is just really the need for support in engaging in telehealth. So oftentimes if there's, we hear about people being able to help, get on the Zoom call or what have you, and that type of support and linking with, perhaps a specialist that's further away is truly a value of telehealth. In terms of, you might be able to have a nurse visit at your home, but your specialist lives across the state because say you live in rural California. So those are all capabilities of telehealth that we've heard about, but not specifically touched on in our research, nor did I hear about that from any of the folks that we interviewed.
Okay. Great to know. Thank you both so much for your presentation today. A lot of good information shared, and I know we have some resources and links kind of with that. So we'll drop that all into Whova so everybody can access that. Thank you all so much, and we'll see you in the next session starting in about 15 minutes. Thank you so much, Diana and Rachel. Have a great rest of your day. Hope to see you in the next sessions.
Thank you.